Okay, so vestibular schwannomas, acoustic neuromas, they are S100 positive because this is mostly because they come from neural crest cells, right? Schwann cells in the peripheral nervous system. These are generally more benign tumors, classically high yield. This is very high yield. They're at the cerebellopontine angle, which makes them infratentorial most of the time. Okay, and we can see an example of that here between the cerebellum and the lateral pons. And I think we've shown, if you've been following the series, you probably have seen this a few times. Okay, we've talked about this tumor quite often. Unilaterally, they tend to be just spontaneous, but if you have bilateral vestibular schwannomas, you want to remember the association with neurofibromatosis type 2. Whenever you see bilateral schwannomas, think NF type 2. That's what they're asking you about. Okay, now again, the molecular target here, S100, because of the neural crest cell origin. And the presentation, just to keep in mind, it's a very unique presentation. You know, compared to some of the other presentations, we said, well, they're kind of nonspecific. New onset seizures, you know, headaches, worse when laying down. But with a vestibular schwannoma, the presentation is very specific to affecting cranial nerves. Now, usually when these schwannomas arise, they come from the vestibular portion of cranial nerve 8, which tend to present with vertigo. And we talked about this a little bit in the vertigo lecture. But they can also affect the cochlear portion of cranial nerve 8. These are in very close proximity, right? They come together to form cranial nerve 8. And so this would classically present with sensory neural hearing loss, right? And remember your Weber and Rene tests that we talked about in the auditory lecture, right? So the Rene test will tend to be normal bilaterally, and the Weber test will tend to lateralize to the unaffected side. And that's how you can localize if there's a unilateral lesion. Okay, they might also have tinnitus as well. And the facial nerve also can be affected because it's in close proximity, so can the trigeminal nerve. And this is just going back to, you know, some of the findings you might see. So if the patient has, you know, put this together, they're not going to usually tell you, oh, the patient has facial muscle motor impairment. They're going to say the patient has an asymmetric smile, or they might have some facial drooping or something like that. You might be thinking, okay, well, maybe this is a stroke, you know, but then they'll show you an MRI and it's going to look something like this. Okay, and then you have to realize, oh, okay, this patient has an acoustic neuroma because cranial nerve 7 is in close proximity to the cerebellopontine angle. Now, technically, you know, this is really taking it a step further. Almost always they're going to ask you about the classic case. But I do want to tell you that sometimes these vestibular schwannomas can arise on other cranial nerves. There is a cranial nerve in particular that I'm thinking about that this will not arise on, and that's going to be cranial nerve 2, because cranial nerve 2 is myelinated by oligodendrocytes, okay? And I think we talked about that as well.